Mute. We're going to go ahead and call to order at 12 p.m. This is the Medical Direction Commission. Shelley, can you do roll call, please?
All right. Daniel Spape, I have you as
present. I'm here.
Frank Walter.
All right, we see Frank online. Thank you. Yes.
Frank, can you hear me? We have some odd audio from you, Frank. It sounds like a cat.
Frank, we may need him to disconnect and reconnect.
Yeah, disconnecting.
Yeah, this is a perfect time to get to talk about Frank, since he can't defend himself because there's some bizarre alien on his line.
I'm game. I think it's Minnie Mouse, though.
Gail Bradley.
Present.
Glennis Zeman. Jason Johnson.
Here.
John Madam.
I am here.
Joshua Gaither.
Here.
Julie Augenstein. Kevin Foster. Michelle Preston.
Present by phone.
Thank you. And Ryan Page.
Present.
Right. Let's test out Frank Walter again.
Hi, can you hear me now?
Yes, that sounds perfect.
Thanks,
Okay,
Frank.
no Minnie Mouse?
No.
Okay.
No cats or aliens, just your voice. Thank you.
Okay, very good.
We did make quorum.
Excellent. We have quorum. Thank you, everyone, for calling in and participating remotely for today's meeting. We have a pretty ambitious agenda, so we'll kind of move through some of these items pretty briefly. Just a reminder for the attendance report, per commission bylaws, members missing 2 consecutive meetings will be getting an inquiry from the Bureau as to whether you are still interested in serving. If your contact information has changed, so phone or email, please send that information to Shelley as well. Just a reminder, since we are online, if you are not speaking, please try to keep your phone or computer on mute. And if you are on the phone, make sure your computer audio is off. For vacancy reports, there is 1 vacancy currently for physicians specializing in cardiac care. We do understand that there are applications into the Governor's Office and Board of Commissions. Obviously, with everything COVID related, I think some of the appointments were put on hold, so hopefully you will be hearing something within the next couple months before the next meeting. But just a reminder that that is still pending and open officially at this time. For a Bureau report, I just wanted to quickly say a big thank you for everyone on this committee. This is EMS Week. I think the last 3 months have really brought a whole new meaning to EMS and what we do throughout the state and throughout the country. So a big thank you to all of your parts in the EMS system across Arizona. With that, I'll turn it over to Chief Mullins for a COVID-19 report.
Thanks, Dr. Bradley. I'll be really brief. I just want to let folks know that both Dr. Bradley and I and several of our staff participate in the State Emergency Operations Center, and we regularly are the burr under the saddle to ensure that EMS is that we are involved in the decision-making process and have the opportunity to share the needs of our community. We're working hard right now to provide information about COVID-positive test results to first responders so that they can ensure that their folks are prepared before they go onto an uncontrolled call. We're working behind the scenes to identify agencies that have PPE needs so that we can help them come up, fix acute shortages. We are locating and sharing information about financial resources that are of help and use to EMS agencies. And then we're working on some PSAs. Hopefully that will be released in the next 2 weeks that will remind folks of the importance of managing their chronic conditions, seeking acute and normal clinical care for those symptoms and accessing the emergency system for time-sensitive illness and injury. Dr. Bradley, anything you'd like to add to that?
No, I think that's a great summary. Thank you.
And then in reference to rules update, we took a month and a half or 2 months off during the preparation phases for COVID-19, but we have begun to work on both the air and ground vehicle and inspection rules, and those will be moving forward later this month or the first part of next month. And we hope to release the skeleton or straw man draft of the CON rule updates in July. The goal is that we want to have a good working document available to the public before the legislative season starts next year. Any questions about our rule updates? All right, I'll go back on mute, Dr. Bradley, and I'll monitor if there's any questions.
Thank you very much. Ben, you're next up for service section update.
Can you hear me okay?
Yes, thank you.
A couple non-COVID related updates. We have several dashboards that are in the works, updating some existing ones and then creating several new ones that we hope are of interest. Some additional years to the trauma dashboard, a falls dashboard, motor vehicle trauma, and then a dashboard related specifically to EMS as soon as IT is able to get those on our website. The trauma registry to AZ Peers linkage is finally complete, and we are working on some instructional materials for the trauma registrars. So thank you to everyone for your patience on that. I know that's been in progress for an extremely long time, but we are hoping to roll out the instructional materials to the trauma registrars as soon as it's moved to production on Saturday or shortly thereafter. Just as a reminder, we're entering the final year of our FR-CARA naloxone grant for first responders and law enforcement. We do have funds available for purchasing naloxone. We know a lot of agencies are coming up on the 2-year expiration date for their naloxone. So if your EMS or law enforcement agency needs to purchase intranasal naloxone, we only have intranasal naloxone. I will put a link in the chat box for how to request naloxone. We also have training. So for agencies that require opioid overdose recognition training or naloxone administration training, it's the curriculum this group approved in conjunction with POST. So it's available for EMS, CE, and POST CE. We do have an online training for that as well. For agencies, please continue to report suspected opioid cases. That's something I will continue to kind of remind agencies. We are pretty confident that's something that's going to be of interest in the coming months as we look back at things that occurred during the pandemic. Something that will be of interest is, what happened with opioid overdoses while people were staying home or while COVID cases were increasing. So please continue to report suspected opioid cases as you have been. And then finally, if you haven't already, sign up for Gov Deliveries. If you're having some issues with Gov Deliveries or haven't gotten any from the Bureau or department, please reach out to Shelley. There were a very small number of people who were having some issues where they weren't getting Gov Deliveries. We think we've gotten that all fixed, but if you have not gotten a Gov Delivery from the Bureau recently, let us know and we're happy to help troubleshoot that with you. It's how we are able to communicate with stakeholders and we kind of rely on it. So we want to make sure you guys are able to get our messaging. And that's all I have.
Thank you, Ben. The Cactus Data Completion Report, I will keep this brief. EMS Council voted to table taking action on the data completion report. Both the reports as well as the table for recommended completion standard and an explanatory letter all went out via email from Shelley. We do really value input that you may have on this. So because of the busy agenda we have, we won't spend a lot of time on this, but just asking that if anyone has some time in the next month or so, maybe kind of review the completion reports and the explanatory letter, and please feel free to give us any feedback you have on that. Next to discussion action items, can I get a motion to discuss, amend, and approve the MDC meeting minutes from January 23rd, 2020? And if you can say your name when you say your motion, please.
Motion
Move to
Jason.
approve, Jason.
I heard Jason, and I think someone else.
I
Nathan.
second that. This is Julie.
All right, Shelley captured that. Thank you. Are there any amendments needed to the minutes? All right, hearing no amendments, and all those in favor of approving the minutes as provided, please say aye.
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 Any opposed? All right, thank you. The meeting minutes are approved. Next up, we will go to the PMD approved drug profiles. So this is a huge change from what we've had before, and a big thank you to everyone who participated in the update process for the drug profiles. As we updated the TTTGs, we recognized that the format of the drug profiles needed to be updated, and so we worked to get them into a similar format and really streamline them. The process that PMD used was looking at NASEMSO as well as 3 other states for both format and content, and then kind of going through and coming up with the best information from all of those. We also had an emergency medicine pharmacist review these as well, just to get some input on some of the information. Highlighted in the packet, there's a few pages where there's some highlighting in yellow, where there was just not consistency when we looked at different sources. And so before we made a final decision on those, we wanted to make sure that those were highlighted for this group to review. Hopefully everyone had a chance to kind of go through that, but I wanted to give a little bit of background of how we got to this new format. Due to the volume, what we'll do is start on the page 4, which is adenosine. And we're not going to kind of go through each line by line, but each page will give people about a minute to kind of see if you have any questions. If not, we'll go on to the next page. If you do see something later on, you know, and we're further down the packet, please feel free to let us know, and we'll go back to that. But we are hoping to get through a few agenda items today. One of the things you'll see in this new format is at the bottom, it actually will contain a hyperlink. So these would link directly to the guideline that contains that medication. So for adenosine, at the bottom you see guidelines containing adenosine, and it would take you to tachycardia with a pulse, adult and pediatrics. So I think overall this is going to be a very nice functional product. I think what we'll do is I'll kind of just go through each drug, and then if someone has anything, please feel free to speak up, and then I'll stop specifically at the ones that we have highlights in yellow. So we will move on next to albuterol on page 5. All right, we will move on to amiodarone, page 6.
Gail,
Yes.
this is Frank. For the albuterol, I saw there were no contraindications. Anybody on from PMD for that?
Yes, great question. So there was quite a bit of discussion on that at PMD. One of the things that we recognized was there was some mention of, you know, do you include symptomatic tachycardia? And so the feeling from the PMD group was to put that under precautions and side effect as a relative contraindication as opposed to an absolute contraindication.
Okay, so any of the contraindications listed in this in these guidelines are absolute contraindications then?
Correct, yes. Thank you for that
Okay.
clarification.
Okay, yeah, no, thanks. I would, you may want to make that clear then, just in some general guidance.
Okay.
I saw the, you know, the box initially that, hey, these are guidelines, and obviously your medical direction, either administrative or online, will supersede these. But you may want to clarify that these are absolute contraindications, and that anything.
Is is there a reason not to name it that, if that's what we mean? Because people aren't going to look at preambles every time they go back to this.
That's a good idea.
Yeah, no, that's a great pickup and idea. I like that. We can certainly, that is an easy fix.
Thank you both.
We will move on to amiodarone. Aspirin next.
You may want to add aspirin allergy probably covers it, but there's type A and type B NSAID intolerance. A is the one that induces asthma or bronchospasm, and B is the one that does urticaria. So I don't know if you want to get in that degree in the weeds. Maybe aspirin allergy is sufficient, but since I saw the aspirin-induced asthma there, you may want to include or aspirin-induced hives. Aspirin-induced asthma or hives.
Okay.
Might be a suggestion.
Asthma/hives, is that your recommendation, Frank?
I just changed it to aspirin-induced asthma or hives.
Okay, perfect. Thank you.
Is there a reason not just to say history of allergic reaction?
You could keep it as simple.
Otherwise, one, that could be fairly consistently applied across the entire thing. The other thing is then it's just more things to remember. And since I don't know of a reason we're giving aspirin that's an absolute reason to give it, I don't know why we'd be giving it if a person says, I have allergies to aspirin. So it seems simpler to me just to say, history of allergy or allergic reaction.
We could just shorten it to aspirin allergy.
All right. So you want to just leave it as aspirin allergy?
Yeah, if people would recognize that, it's simpler, and that could manifest as either asthma, like bronchospasm, or hives. Yeah. Allergies probably.
I think that's perfect. Perfect. Yeah, keep it simple.
Yeah.
Okay.
Yeah.
All right. Aspirin allergy it is. Thank you.
Thank you all.
Atropine next.
Bradycardia doesn't need to be capitalized under indications. Neither here nor there, but typography.
All right. Calcium.
I'm looking at albuterol and Daily Med, and it does say that if somebody has a history of allergy to albuterol, it's contraindicated.
So one of the things.
Yeah. By the way, I was going to bring up, although I know we have a lot to cover. I know there are lots of drugs where the allergy to the drug itself is incredibly rare, but the vehicle that it's given in to the patient, they may have allergies to. So the reality is some people can have allergic responses to drugs that it doesn't make any sense they're having an allergic response to. So it does seem like history of allergy on essentially everything is a reasonable contraindication.
And the PMD group did discuss that, and they had elected to, rather than putting that at each one, they kind of thought that was just part of normal paramedic training, was if you're allergic to medication, not to give a medication.
Yes, I agree with that, but it's interesting that are we only going to highlight it when we're really serious about it? Like with, aspirin, and Yeah, or you know what I mean? We really mean it with aspirin. We kind of don't mean it with these others. I don't know if that's a consistent message.
That's fair. Any other opinions on the line? We can certainly add in under each one contraindication, allergy, if that's the group's preference.
I think it's a good idea. You may want to put it on the bottom instead of the top, or you know, so that they don't say, "Hey, this is the same old dang thing again," and then read the ones that PMD was most concerned about. You know, like atropine, symptomatic. Bradycardia without evidence of cardiopulmonary compromise, and then put below it allergy. You know.
Okay. So under absolute contraindications, it would just be listed for each drug just to make sure we capture this. Like the next drug is calcium chloride. So under absolute contraindications, the third bullet would be allergy to calcium chloride. Is that correct?
Yeah, it'd be the fourth bullet here on calcium chloride. I think it'd be a new bullet.
Okay. Sounds good. Next is calcium gluconate, page 10. We've got the topical gel on page 10, and page 11 is just regular calcium gluconate.
When we say for external use only, would that mean not putting it in the conjunctiva too? Do we say for cutaneous use only?
Under the calcium gluconate gel, you're saying where it says external use only?
Yeah, because we don't want it in the eyes either.
So maybe a new bullet, do not apply to conjunctiva.
Yeah, or you could just say for skin application only if you want to use plain English, or for cutaneous use only.
Okay. So for external use, maybe external / cutaneous use only.
Yeah. I don't know if we need the word external if we say for skin application or cutaneous use only. I'll bow to the wisdom of the group.
Okay. That sounds good. We'll update that.
For application to skin only.
Mm-hmm.
That simplifies it. I like to skin only.
Thank you.
We'll go to the next, page 11, calcium gluconate, IV.
There's controversy about the digoxin toxicity, but I'm fine leaving that in.
Thank you. We'll go to dexamethasone next.
Here, since we say hypersensitivity to any component of dexamethasone, including sulfites, if we wanted to say, you know, we could put that one at the bottom, you know, to follow the, you know, allergy, and we could simplify the wording of this maybe, unless PMD felt strongly about it, I'm okay with it.
Well, do you want to just say contraindication? We'll just say allergy to dexamethasone.
Yeah.
And do you want to include sulfites or no?
This is Dan. I think that unless there's something really, really incredibly important or instructive, to me that is just unneeded information.
Yeah, it's nice to know, but if somebody wants a quick drug reference, you know, allergy to dexamethasone.
Okay. All right,
You know,
thank
just
you.
allergy. allergic reaction, whatever we're using for all of them.
Okay.
Yeah, because any of these preps might have it, so I think we're covered there. You know, it's good to know that some things do have sulfites, but it won't change this simple, great presentation. And kudos to everybody on PMD and those who worked on this. They look good.
On to dextrose. All right, diazepam. Next, diltiazem.
I do have a question here. I'm not sure what that means. I understand narrow complex tachycardias. I'm not sure why we're putting the N dash and then AFib and A flutter. Should we just keep it simple, narrow complex tachycardias?
On the diltiazem.
Yeah. Or if we really mean AFib and A flutter with a narrow complex, maybe we ought to say it that way. Was the idea there just saying, hey, we don't want you to give it to sinus tach?
I think that was more the goal, was maybe instead of tachycardia, it should say tachyarrhythmia.
Tachyarrhythmia would be a good one. That's true.
Yeah, that'd be fine. And then just get rid of AFib, A flutter.
You know, some of this we did include just because it's educational. So I think the paramedic programs tend to kind of use these when they teach their students. So some of this is more than kind of what your normal paramedic would know, but just kind of from an educational. But I don't know if that makes it worthwhile including that.
This is Dan. If that's the case, then I haven't been thinking about this that way at all. And I think it's a completely different review of going back through and saying, hey, what are the details that we want? Because if we think this is needed in order to help with that kind of special educational thing, then there's all kinds of caveats on lots of drugs, and I prefer to keep the educational purposes where they're explicit and they've been reviewed from that perspective, because otherwise there's lots of holes in this as far as I'm concerned.
So your suggestion would just be narrow complex tachyarrhythmias?
To me, on this, I like the ideas of the simplicity. The things like, you know, if they have an allergy to it, don't give it. And there's lots of things. When you think about all the different drugs and all the different potential things, and sometimes these are mixed with this drug, and often that vehicle is used and all that kind of stuff. It seems to me like if this is going to be for educational purposes, then we would have needed to think of each one of those with that caveat of, okay, are we also including the little tidbits and so forth that we want? And I think that's been much more random on this, and this doesn't seem to me to be primarily an educational tool. That's just my thought, unless I completely misunderstand the use of this.
This is Nathan. I agree.
So we had a little overlap there.
I agree with Dan on that. We just need to keep it simple.
I agree. Let's just say narrow complex tachyarrhythmias is what's suggested, and get rid of the N dash and atrial fibrillation / A flutter.
Okay.
Yeah, I agree. This needs to be kept as simple as we can, and any education should be up to the medical director.
Agreed.
And feedback that I just got via a paramedic instructor says, quote, I like what I see. It's basic and to the point. So this is someone who does teach paramedic programs and students, and they would be utilizing these. All right, next one.
And then all these are going to be cleaned up instead of known hypersensitivity, just allergy as the last bullet for all of them, right?
Correct, yes.
Okay, great.
All right, we'll go to dopamine next. This is one of the ones that we do have highlighted in yellow. So one of the things that will be a discussion piece on the next item on the agenda is going to be kind of what to do with dopamine. So we had not spent a lot of time at this at PMD, and so we kind of just took some of the dosing that we had in our previous version of the drug profile and have taken this forward. Highlighted specifically is the indication, treatment of refractory cardiogenic or distributive shock. That was the indication that was in there before, but we'll kind of get into a little bit more of the discussion regarding dopamine, whether it is a mandatory or optional agent moving forward. But this is just why that is highlighted in yellow, so I wanted to give that explanation. And this is a two-page one versus the others, because it does have the table on the next page.
I do have one suggestion for format for every page of this. And this is something, you know, since we teach a lot of people, we've gone away from using just the hyphen between, you know, like 5 to 10 minutes or 1 to 2 mics per kilo per minute. And the reason we've gone away from the hyphen is somebody that looks at this quickly, or maybe they've got PPE on and they can't see very well, they see 1 to 2 as 12, for example. And so just for brevity, rather than putting the words TO in there, which would be an option instead of the hyphen, at least we ought to use the N dash, and we did see that N dash before AFib and AFlutter. So I would suggest that, just for clarity.
So just a longer dash?
Yeah, it's called an N dash, like EN, like the, usually you hit, I think it's controller shift minus, but again, you could just use, you know, on page 15, there's an N dash between tachycardias and atrial fibrillation, for example, under diltiazem. That longer N dash separates the numbers better. So
right, Shelley is on it. She is taking notes.
Got a strong nod going.
Okay, very good.
Thank you for that input. That is useful.
And here we see tachyarrhythmias, which is a great suggestion. Since we're separate, I don't know who suggested that for the other one, but that's a great idea. And it's here on dopamine under precautions.
And I'm sorry, what did you want done with that?
Oh, nothing. I'm just saying, you know, we may want to look at tachycardias and do a word search and change them to tachyarrhythmias if that's what we mean.
Okay.
The other brevity thing that I'd suggest, and we've gone through this, you know, with teaching 20,000 some folks, just especially when you want things succinct, like instead of precautions, A and D side effects, just an ampersand, and up above pharmacology A and D actions, just an ampersand, and just shorten everything up.
Right. Next is epinephrine. Highlighted here, I just wanted to get some input in terms of the peak effect. We could not find consistent information on this, so I just wanted to see if these are comfortable numbers that are listed on here for the IV and IM dose. Frank, if you could give your input on this, I would appreciate that.
Sure. I agree, and lots of smart people on PMD and your good EM pharmacists have looked at this. Since it's such an old drug, it's hard to find this data. So if you all looked many places and came up with this as a a reasonable thing, I'm okay with that.
Thank you.
Can I ask who the EM pharmacist was, just out of curiosity?
Amber, I think you were on the line. It was someone from down in Tucson.
Yeah, it was Chris Edwards looked over them.
Okay, great. And again, congratulations to you, Amber, and the whole PMD and Chris. This all looks really great.
We'll go to accommodate next.
I guess I've got a question here, just for simplicity. Should we delete that long second bullet under pharmacology and actions?
Do you have a better option to put in there? We try to include a little bit of pharmacology, and that was the best that we found, kind of looking at the different resources. If you have something you would recommend instead, I'm happy to substitute that.
No, I mean, it's okay. It just goes into a little more detail. And again, I was just going down the whole simplicity pathway. It's okay.
Next, we'll do fentanyl.
Just for simplicity here, under the first bullet under pharmacology, you could just say opioid agonist analgesic to shorten it up.
Opioid agonist.
Analgesic.
Okay.
Yeah, that's good.
Sounds good.
And then unless you've got a true thing from the poppy, I'd substitute, I do a word search and substitute opioid for opiate.
All right, we'll take a note for that. Next up is glucagon. All right, next is oral glucose. All right, well, next to hydroxycobalamin.
Hey, Gail, it's
Yes.
Shari. Sorry to go back. Just a question on glucagon. We have listed in there not first-line treatment for hypoglycemia and should only be used in patients when they're unable to obtain an IV.
Correct.
But we have administration as IV.
Yeah, that's a good catch.
Yeah, great catch.
Great.
All right.
Very good.
Yeah, thank you very much for catching that, Shari.
You may want to, yeah, no, thanks a lot. That's important. We would give it IV though, it's going to be IM for hypoglycemia, so that's great. But if we're going to give it for symptomatic bradycardia, for beta blockers or calcium channel blockers, that would be IV or IO.
You have for the onset, peak, and duration for those, Frank?
Onset is almost immediate, 1 or 2 circulation times.
Okay.
Let me see if I can find something for you there. But again, since and I guess that brings up the other question, do we need to say IVIO or that's just an education thing? They're virtually equivalent.
We've just been putting IV for the others because the treatment guidelines specify that any time an IV is listed, an IO is sufficient.
Okay, great. I'll try to find the IV stuff for beta blocker and calcium channel blocker for you.
Okay, thank you.
Yeah.
By the way, since we've spent so much time on glucagon already, this is one of those that is a really good example of why is it in the box at all? Why do we? This is the drug that a really large major EMS agency corporation in North America that buys gigantic amounts of drugs in bulk for pricing reasons. They did a 1-year study on rarely used drugs, and they spent $1.4 million on glucagon for drug replacement across all of their many thousands of sites, and had 0 usages. So I think it is worth us continuing to always comb back through of why is this here. So I suppose there's no reason to waste a bunch of time on why in the world is glucagon here, because you could argue that because it doesn't get used, it's not going to hurt anybody. But on the other hand, these drugs are costly and there's disruptions and so forth. So just a thought, this is really great that we're getting all this detail, but it doesn't get used.
We'll get down to the medication given report. You'll be surprised. Attachment V-.E. Any other comments on hydroxycobalamin before we move on to ipratropium?
Dan's comment on glucagon just sparked my memory of a previous discussion on MDC regarding glucagon, that the minimum dose for an adult is 5 to 10 milligrams IV or IO. And I have a recollection that most people aren't even carrying that much. They're carrying maybe 1 milligram, 2 1 milligram doses for IM administration for hypoglycemia. And if that's correct, then we can just take out the whole IV for symptomatic bradycardia.
Yes, you are correct. The minimum required quantity is the 1 milligram based on the cost and the use of this. That was a request that had been brought forward by stakeholders. So are you recommending that we take off the IV component?
Yeah, I think so, because if you just give 1 milligram IV to an adult, nothing's going to happen.
Okay.
You know, if somebody's got a symptomatic metoprolol poisoning, for example, or something like that. So if we want to keep things simple, you know, that was a great catch on the IM, and that, you know, if you want to leave that indication in there, that's fine. The symptomatic bradycardia, it's true, but they don't carry enough to actually do anything about it. So for simplicity, you may want to remove it. I'll bow to the wisdom of the group on that.
Okay. Any other further comments on the hydroxycobalamin before we move on to ipratropium? Next up, after ipratropium.
I'm just deleting the none and adding allergy.
Sorry, can you specify that? What I broke up a little about the allergies?
Under contraindications, it just says none here. I would delete none and add allergies, like we're doing everywhere.
Yes. Yep, that will be we'll go through and add that to each guideline or each drug profile.
Yeah, and the only reason I mentioned it said none specifically, so.
Next up, ketamine.
There's a nice example of the end dash under peak effects, 30 seconds to 5 minutes. See how it separates it.
Shelley's doing a big nod for you.
Very good.
All right, lidocaine next.
The only question I had here is, do we need to put HCl afterwards?
I will leave that up to you guys.
I don't think so. We're not going to mix it up with the other preparations of lidocaine in the box.
Okay. So just lidocaine minus the HCl.
Yes.
All right. Next up, lorazepam. All right. Next up is magnesium sulfate. Next, methylprednisolone. All right, next, midazolam. You'll see on this one we do have some highlights in yellow. Again, Frank, if you have any input, this is another one where we saw some conflicting information regarding peak effects for both IVIO and IN versus IM.
Sure. And I did look at this in preparation for the meeting. I think we're fine on the peak effects at 3 to 5 minutes. This is the only place we list IO different than IV. So if, you may want to take it out since we've got that superseding thing that says IV and IO or
Sounds good.
equivalent, I'll borrow the wisdom of the group there. I did look up in Daily Med, from National Library of Medicine, National Institute of Health, basically the package insert, and it says peak effects there are 30 to 60 minutes.
IM.
For the IM, yeah.
Okay.
Yeah, let me just pull it up here. I've got it up. Double check.
Thank you. We will get that changed.
Yeah, onset sedative effects after IM in adults 15 minutes with peak sedation 30 to 60 minutes following injection.
I don't have this one in front of me right now. Is this not the midazolam for seizure? Is this specific, or is this across conditions?
Seizure, sedation, agitation, excited delirium, uncontrolled shivering, and hyperthermia are the indications listed.
Yeah, thanks, Frank. So just an interesting comment. It doesn't speak directly, but it speaks clinically to what you just said, Frank. What was interesting in the Rampart study is that even though it was set up as a non-inferiority study, it really was so powerful that IM was so much better. And essentially the only really good conceivable way was probably that the dose started earlier, and on average you got the IM dose around 3.5 or 4 minutes earlier than IV, and yet you had a dramatic difference in basically all of the outcomes, including mortality. And the best explanation was you get the drug on board much faster. So that would speak against that it takes 15 to 30 minutes to get there with IM. Just a clinical correlate comment in a setting of a really, really well done clinical study where it seemed that there was seizure effect much faster than what that's implying.
I agree, Dan. And like I said, I just went to Daily Med to pull it up. Amber, any thoughts on that from your discussions with the PMD?
I didn't hear your question, Frank.
Oh, yeah, so, I looked at this mostly from Daily Med or other pharmacology sources, but Dan's saying, hey, in the Rampart study, effects were seen sooner, onset was seen sooner than 15 minutes for seizures. Any comments on that discussion that you guys had at PMD with this?
I don't think that came up specifically.
And then the only other question I had is I looked at this under contraindications. I get respiratory depression. Is there another term for neurologic depression? Will that be understood to be altered mental status or decreased level of consciousness?
Yeah.
Okay, great.
Yes, I can't see the question. So, Shelley, can you read that question regarding ketamine?
Sorry, I didn't have my microphone on. A question says, how about schizophrenia as a contraindication for ketamine?
That's a good thought.
Or perhaps use caution with this patient population instead of an absolute contraindication.
Maybe that's why it's not there.
All right, so I got the suggestions under precautions and side effects, used with caution in patients with schizophrenia.
Yeah,
I like that.
I agree.
All right.
Suggestion.
Thank you. We'll go back now to page 32, morphine.
These are usually going to only be single administrations, or maybe two if there's a long transport. Is that correct?
I think typically most agencies kind of do their single, and then if they need to repeat, they repeat if they have a longer transport time.
And the only reason I ask is just with repeated dosing, the metabolite morphine 6-glucuronide builds up in people with renal failure, and the metabolite's equally active, and so you can get much more sedation. But I don't think that's an issue in this setting for a single use, or maybe twice in round.
All right. Thank you. Next, naloxone. We'll make sure we remove the IO under administration.
I do have one other thought here on morphine. It says respiratory and/or CNS depression. I personally like that terminology rather than the previous neurologic or respiratory depression. It seems to make more sense to me under the morphine sulfate than the midazolam hydrochloride. Can we get rid of the hydrochloride there too?
Yes, hydrochloride's gone. And then we're going to use the respiratory CNS depression. We're going to use that language, add that to midazolam. Is that your request?
Yeah, that'd be great. Yeah, respiratory and/or CNS depression.
Sounds good. We will clarify that. All right. Anything further on naloxone? All right. Next, nitroglycerin, page 34.
I just have a question here. We are getting pre-hospital EKGs. I don't know if the medics would recognize the potential for an inferior RV infarct. I think probably hypotension's, you know, we just all know you could drop preload. I don't know if there's a good way to indicate that, or hypotension's good enough.
I think the hypotension is the best way of describing that, unfortunately.
I'm fine with that. Thanks.
Next up, norepinephrine. This is the only one, just FYI, had very specifically listed in two separate areas, infusion pump only. So it's listed at the top and then also under administration. So just that's why it does look a little different from the other guideline or drug profiles. All right, we'll go to ondansetron next.
Here, should we say prolonged QT syndrome or just prolonged QT?
I think prolonged QT describes it well enough for this type of report.
Thank you.
Next, phenylephrine nasal spray. Oh, did I miss oxytocin? Yep, I'm sorry, I missed oxytocin. There aren't any guidelines included. Oxytocin, Shelley just asked, do we need to add it to the guideline? We do not have any statewide treatment guidelines for oxytocin. It was used a total of 7 times in the state of Arizona in 2019, but the vote to remove that from the drug box was voted down at PMD. So it remains for now. Phenylephrine nasal spray next.
I just couldn't help but comment that I'm sure in those 7 cases it was entirely life-saving.
Yes.
Thank you for that comment.
All right, next, prelidoxime autoinjector.
I've got a question here under phenylephrine nasal spray, facilitation of nasotracheal intubation. Are folks doing any of that?
Surprisingly, yes. There are still some people that are doing that, yes.
Okay. You know, I used to love to do it too. And I guess then the other indication would be, would we use it for epistaxis?
I still do.
I guess for EMS, I don't know that they're historically trained in that. But, I mean, it's certainly reasonable. I just don't know if we would have to put that somewhere else in terms of a training piece for EMS.
So is this really still in here for use in nasal intubation?
Yes.
That's the listed indication.
Yeah, I'm with Frank. I've been around long enough that there have been some cases where I was absolutely loath to put patients down. Alert, bleeding super fast in the back of the throat, where they were still alert enough that I could keep them up and they could suck it in and so forth. But the reality is, except for those of us who trained way back, the number of people who do this in almost any setting is just really, really small. Whether or not this drug makes a difference in that setting, who has any idea? Unless there's another indication for it, is this a, does this even get used? Do you know that, Gail? You've had some drug usage info. Do you have it on this?
Let me. It was used 36 times in 2019.
And I certainly have no problem in significant epistaxis. The likelihood you're going to really hurt somebody, you know, with a proper dosing and so forth is probably pretty small. But I mean, it's another one of those of, I'm just kind of surprised. How long has it been since anybody actually thought about this? And I wonder if any of those 36 usages were for nasal intubation. But in any case.
All right. So is there a request to add epistaxis? Is that the request?
That was Frank's request or question, and my request or question is, why don't we just get rid of it?
We do use it for epistaxis in northern Arizona. Our transport times are often a little longer, and we had a specific ask from paramedics to have it. We also have a couple paramedics that, for whatever reason, really love to do nasotracheal intubation, so, and they're good at it. So I wouldn't want to remove it right now.
Dr. Preston on the phone from Havasu. I would like to keep it in the box as well, mostly for epistaxis.
We would just have to add the indication for epistaxis.
All right, so in the interest of time, it sounds like we're going to add under indications. We'll add a second bullet for epistaxis.
That's good.
Thank you.
All right. Thank you. Was there anything further under prelude oxime autoinjector?
I think you could just get rid of the chloride, just pralidoxime. It is chloride, and other countries use like pralidoxime iodide and things like that. But I think simpler is probably better.
Agree.
Sounds good. Proparacaine ophthalmic, and I'm guessing the hydrochloride removal again.
Please.
Likewise, yeah. The only other thing too, on the pralidoxime, just an editing thing, after the E period, G period, there should be a comma before Tabin, Sarin, and Soman under indications.
Okay, Shelley's got it.
And my recollection on this is some people still wanted to keep the proparacaine or proparacaine, however they like to say it, rather than switching over to tetracaine that doesn't need refrigeration. Is that right?
Correct.
Okay. Here we need the comma after, comma before and after EG under indications here too.
Thank you. Next, rocuronium.
You may want to widen the indication. It surely is indicated when SUX is contraindicated, but that makes it seem like you should use SUX first. And I don't know that that's true, honestly. You might want to just shorten it up, induction of paralysis to facilitate endotracheal intubation, period.
It's very true. It does give a push with putting that in there with succinylcholine.
And I think the history on this was just some of the controversy regarding pre-hospital RSI and just kind of efficacy of it. And so the thought was to utilize a shorter acting paralytic in the pre-hospital setting. I think that's kind of the historical component behind that. But I'm happy to take whatever the group suggests.
For any of you, and I'll just speak for myself, good judgment comes from experience comes from bad judgment, but you'll only wait for succinylcholine to wear off once before you never do that again. and either, move on to an alternate contingency or emergency or a cry. So I'd be happy just taking off where succinylcholine is contraindicated, but I'll bow to the wisdom of the group there. That 10 minutes is like an eternity, and the patient's deteriorating.
I'd like for just the induction of the paralysis too, and just leaving succinylcholine terminology on there, because the rest is just the medical director's education of the paramedics.
So to put a period after intubation then?
Correct.
Yeah, no, thank you.
All right, so it would read, indications, induction of paralysis to facilitate endotracheal intubation, period. Everyone comfortable with that?
Yes.
Okay. Next page. Sodium bicarb.
I do have a question here. Is only the 8.4% and not the 7.5 for use in pre-hospital here in Arizona? And the reason I ask that is because we've all experienced the shortages of sodium bicarb intermittently. And to the extent that we couldn't get 8.4%, I'd be comfortable using 7.5, either in the hospital or pre-hospital setting.
So Frank, is there any reason not just to put or?
Yeah.
And can we do that?
Yeah, I sodium bicarbonate 7.5 or 8.4% would be my suggestion. 7.5% or 8.4%. We could put the N dash, or no, the or between them. Yeah, you're right.
Yeah, and Gail, in a shortage, that saves you and the Bureau a whole bunch of administrative schmaltz.
Sounds good. And we would need to update the drug table with that as well, because currently the drug table specifically states sodium bicarb 8.4%.
And then here we
are we able to take that action, Gail? I think we're able to take that action, right? Because that's a clarification of the drug usage.
So we are going to be making proposed amendments to the drug box in the next motion, so we would need to potentially have that discussion there. But we can certainly, on the drug profile, we can make the decision to add that to the drug profile now, and just note that we would also need to update the drug table.
It sounds like a good plan. Here we also have IV/IO. So if you want to eliminate the IOs everywhere, since there's some explanatory verbiage elsewhere, that's fine.
Yep, got it. It's on the list. Thank you. All right, next up is succinylcholine. And we'll get rid of the IO as well.
I do have one question back on sodium bicarb. I don't know if we need that N dash between cardiac arrest and when hyperkalemia or tricyclic antidepressant overdose is suspected.
So just a shorter dash?
Well, I don't even think you need a dash there. Cardiac arrest when hyperkalemia or TCA overdose is suspected.
Okay, no dash it is. Anything else in succinylcholine outside of deleting the IO?
I would, the musculoskeletal disorders such as muscular dystrophy, spinal muscular atrophy. I also would put in there paraplegia and quadriplegia.
Okay.
Because those denervated muscles are going to upregulate their nicotinic receptors. So when they see that succinylcholine, somebody with paraplegia or quadriplegia is going to get hyperkalemic. So it might.
Excellent.
I agree, and that one really matters.
That one really matters. That'll kill people. So it probably needs a separate bullet because it's more than a musculoskeletal disorder. You could put
yeah, and it's also common.
Yeah, no, we see a lot of people with paraplegia or quadriplegia. So you might have separate bullets for each, or one bullet with paraplegia and quadriplegia.
We'll add a separate line, so it's its own bulleted line, paraplegia and quadriplegia. It's a great pickup. Thank you.
Thank you.
All right, next line, 44, tetracaine, or page 44. All right.
There's just rather than the word affecting with an A, it should be effecting with an E, which will be the first bullet under pharmacology and action, second line.
Thank you very much.
Yeah.
All right, and last but not least, thiamine, which I already know, we're going to get rid of the HCl. And because I know this question would come up because I had the question myself. Thiamine is used extensively in the state of Arizona.
It's an essential nutrient. I like that.
Yes. All right.
And here we've got the IO again.
All right. All those in favor of approving the PMD-approved drug profiles with the recommended amended changes from MDC, if we could say aye.
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 Any opposed? All right, those are approved. Thank you very much, everyone. That was a huge effort. I really appreciate Franco's work on this and PMD and everyone who's participated in getting these put together. This is a big undertaking. I think will really be a huge improvement for everyone across Arizona. Next up is need a motion to discuss, amend, and approve the PMD approved updates to Table 1. If I can get a motion. A second, please.
Motion. Motion for May 10.
I heard Madam for first.
Frank for second.
Okay, Walters for second.
Thank you. So I will give a little bit of background on this. So one of the things that we recognize we need to just put back into the drug table that had come off at some point. If you look under key, there's a 2 asterisk with immunizing agents are the list of medications approved by the CDC Advisory Committee on Immunization Practices. That just links you back to a specific guideline in terms of what can be used for immunizing agents. So we wanted to make sure that that was added back in. PMD had taken on the project of looking at some medications across in the drug table as we were working on the drug profiles to look and see, are there medications that we had in our drug table that really aren't used within Arizona and could potentially be taken out of the drug box. And so there were several that were discussed at PMD. There were initially 5 drugs with the recommendation to remove them, which were activated charcoal, nalmefene, oxytocin, vasopressin, and verapamil. Oxytocin was voted down, so the ask from PMD was to continue to carry that, and so that motion did not pass forward. The 4 medications that PMD is suggesting be removed from the drug table are activated charcoal, nalmefene, vasopressin, and verapamil. So I will give that background and then let that be up to the group for any further discussion.
We've had some cardizem shortages, and it's nice to have a backup drug when we don't have any cardizem available. I think with some of our drug lot changes, we need to think about the possibility of shortages and being unable to get medication.
So PMD did have a lot of conversation regarding that. I think the feeling from the PMD group was that verapamil has not been within the standard of care and it's not in the national guidelines as a medication for EMS. And so really in terms of risk and benefit ratio, when you look at the risk associated with verapamil administration and hypotension. The recommendation from PMD and also the national recommendation is not to utilize verapamil anymore.
I would concur with that recommendation.
Agree. It causes a dosing problem too. So even when there is a shortage, we have problems with misdosing concerns.
Just an FYI, I'm okay with taking the activated charcoal out. There is an international group re-looking at all the gut decontamination techniques. I served on that first group back in '97. There was a second group that validated that, but there's a third group looking at it now. So again, I think it's fine to come out now. You know, we'll see what they come up with. They have not produced that, but at least two large international panels have said no many years apart. I think 97 and 2004, 2007, but it's being looked at again.
Thank you. So those are the 4 recommended drugs to be taken out. The other last piece for discussion was when you look at page 3, currently there is the option for norepinephrine on an infusion pump or dopamine, and the recommendation from PMD is to make both of these optional agents. The thought process behind this is that the treatment guidelines had been updated to really transition from vasopressors, unless you had an infusion pump, and really move towards push-dose epinephrine due to safety and efficacy, and just making sure that people when we looked at the overall data and use for dopamine across the state of Arizona, and then recognizing how rarely that was used in a drip format. And so the recommendation from PMD to MDC for consideration is to make both of those optional agents, with the understanding that the epinephrine quantities required includes enough for your cardiac arrest resuscitation of 3, plus enough to also potentially do push-dose epi if you did get ROSC and were doing transport on a patient.
Was there any discussion of removing them altogether rather than just moving them to optional?
The rationale of making them optional is that some agencies do have norepinephrine and do carry an infusion pump, and so that was the rationale for not removing that if they do have the capability of administering it with an infusion pump. With dopamine, some agencies may be reluctant to transition to using push-dose epinephrine, so this would at least give them the option, even though it's not an ideal vasopressor. This would at least give the agency and their medical direction an option for that.
Well, I'm certainly in favor of at least moving it to optional. If not, I'd be happy to have them removed. But
I'm okay with optional, and I'm also seeing pralidoxime chloride here, so there'll probably be HCLs and chlorides to be removed here too.
And is that on all the medications, Frank? You would like that removed?
I think just for brevity, yeah. I mean, we just call it thiamine. We don't call it thiamine hydrochloride or thiamine HCl. Or dopamine hydrochloride, or or ondansetron chloride,
ketamine, etc. You're right.
And like I say, there's only one pralidoxime prep in the U.S., so there's only going to be pralidoxime chloride here in Arizona. So I don't think we need to clarify from the iodide that's in other countries like India, etc.
Okay. And then Shelley just clarified as well for sodium bicarbonate will be 7.5-8.4.
I wouldn't use a dash. I'd say 7.5% or 8.4%.
Okay. Okay. Thank you for clarifying.
Yep, and I think Dan suggested the or.
Sorry, my microphone just died. Did you guys hear my table?
No, I didn't hear anything.
I gave a really nice summary that I will repeat, and then I looked down and I saw a dead mic. Okay, sorry about that. So I'll summarize the changes, and then we'll just take a vote to approve. The summary of recommended changes are to remove activated charcoal, verapamil, nalmefene, and vasopressin. We'll have optional agents, norepinephrine on infusion pump or dopamine. All references to chloride or HCl will be removed. And on page 3, sodium bicarb 7.5% or 8.4%. All those in favor of approving changes to table 1 as described, please say aye.
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 Any opposed? All right, thank you very much. All right, next up, discuss, amend, and approve PMD approved treat and refer guideline changes. So these are, again, just to give a little bit of background for this, any agency that does get approved to do treat and refer and be a treat and refer recognized agency, their individual medical director would need to approve whatever treat and refer guidelines they utilize. We at the Bureau, we're committed to at least provide an option that an agency could implement by essentially adopting our treat and refer guidelines and utilizing those. PMD had approved these. I have since gotten some small recommended changes that have been put forward to make. I just don't know if we have time at this for us to go through each of those pages because we only have 7 minutes left. I certainly think that in the current format that PMD approved that they are usable, and potentially for the next meeting we could bring forward some of the recommended changes. But we just officially would need MDC approval on these treat and refer guidelines, which again are optional, and any agency's individual medical director could make any adjustments they see fit for treat and refer. So can I get a motion to approve as presented?
Motion from May 10th.
Second, Jason.
Any further discussion?
Just to clarify for me, these have nothing to do with the COVID-19 changes. These are everyday.
Yes. Correct. Thank you for clarifying. So these are not covered under the governor's executive orders. So this is really nothing to do with COVID-19. This is just if an agency applies to be a treat and refer recognized agency with the Bureau of VMS and Trauma System, and they would need to demonstrate a number of different processes, including a CQI plan, and they also have to let us know which treatment guidelines they're utilizing. All right, any further discussion?
These, I guess I have a question here on this respiratory distress one.
Okay.
Maybe it doesn't mean respiratory distress, but if it really means respiratory distress, I don't think they should be treated and referred.
So I think historically, these have been used for, I think, several years, at least here in Maricopa County by a number of agencies, for kind of those patients with mild asthma type symptoms, where they get a single SVN treatment, they feel better. As opposed to it being a refusal, it's now kind of a treat and refer case scenario. So that has been used pretty successfully in Maricopa County for at least, I think, probably 5 years now from treat and refer agencies.
Should we call it wheezing then?
So wheezing or bronchospasm?
Yeah, something like that. Because I mean, respiratory distress seems to signal they shouldn't be treated and referred.
We clearly don't mean respiratory distress, even if that's what we've called it. That's not what we mean. I mean, it's so hard to conceive of somebody who's in true respiratory distress, you know, with an albuterol, and you say, okay, fine, you can go to your doctor now. So I agree with the verbiage is misleading, so we might as well clarify it and simplify it.
So how about we change the actual title, and at the top, instead of respiratory distress, have it read bronchospasm?
I'm okay with that if others are, yeah. Or bronchospasm and wheezing, wheezing or bronchospasm, or just bronchospasm. And then the verbiage would have to be changed down below too.
Yeah, I agree with that. I like bronchospasm.
Yeah, I'm okay with that.
All right. Any further discussion?
And then the first sentence, it could just go to bronchospasm with wheezing or decreased air entry.
Yes. Got it for both areas. Thank you.
Thank you.
All those in favor of approving the treat and refer optional guidelines with the amendment for respiratory distress to be changed to bronchospasm, please say aye.
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 And any opposed? All right, excellent. Motion passes. Thank you. Next one is medication given report. This is a report that had been requested a while back, and Anne has done a lot of work on this, and I think it's a useful tool to look at. It kind of speaks to some of the questions that were raised earlier in the meeting regarding how frequently medications are used. When you look at this data is taken from agencies to report their EPCRs to AZ peers, and so you can see some of these medications. There's obviously a large amount of use. There's other medications where it's relatively small usage. So I think it's an informative document as we move forward and we look at our drug table. Certainly, you know, in the like I mentioned, oxytocin did not pass, but if we see those numbers start decreasing or increasing, that may further guide some of our drug table uses. So more of informational, but it's a lot of work that goes into this, and this is very helpful guiding our decisions and recommendations from PMD in terms of whether we had that drug removed from the drug table. A big thank you to Anne for putting this together.
Just a quick question. Under the vasopressin, there were 2 uses in 2019. What were the indications, I wonder?
So we don't look at specific charts from AZ peers to make decisions, but what we were able to do is look at agencies, and so what we found where vasopressin was used, it tended to be from Air Medical, and so our assumption that this is being used as an IV vasopressor as opposed to some of the Air Medical units, you have an RN that's administering drugs. So our assumption is that's likely where it was utilized.
Okay, thanks. Just curious.
Next item, we do need to update our bylaws this year. We are due for that. So if I can get a motion to discuss and approve the creation of a bylaws update work group.
Motion from Maytem.
We get a second?
Second.
Thank you. Who was the second, sorry?
This is Dr. Preston in Havasu.
Thank you. Historically, we've brought members from the 3 statutory committees together to make recommendations and update the bylaws so they're consistent. So if there's anyone on this meeting that would like to participate in the bylaw update, you can either let us know currently or send Shelley an email and we'll make sure you get added to that list. Is there anyone that would like to volunteer at this time? Otherwise, you can email us if you're interested. Can vote to approve creation of a work group?
Aye.
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 Thank you. Any opposed? Any volunteers?
I'll volunteer for both. I already went volunteered for the EMS Council side. Whatever you need, Dr. Bradley.
Thank you.
And this is Jason. I can probably help out too.
I think it was Dr. Madam, correct?
Yes, Maytem first, correct.
And Jason, I can help out.
Thank you. Got you too, Jason. All right, so we are technically at 1:31. I am actually really impressed that we got where we did on the agenda. We are pretty optimistic. We have not hit the standing committee reports. It is up to the group. We can either quickly cover those or we can adjourn. We did actually reorder the agenda to try to get our action items covered because we knew we had a busy agenda today. So I will leave that up to the group if you'd like to go through the standing committee reports or if you'd like to adjourn.
I'm okay with standing committee.
Yeah, I have time too.
Is there anyone that would like to stay on for the standing committee reports?
Maytem will stay.
And this is Jason. I can stay.
So if anyone that does not want to stay, you can certainly hop off. We'll see if we still have quorum to cover. Actually, there's no action items, so we can just quickly do those for those who want to stay on the phone. So because they're not actual action items, we've covered those. If we lose quorum, we can still give the reports. I believe those are the correct meeting rules. Shelley's nodding her head. She keeps me in line.
Yeah, you're good to go. Mr. Terry.
All right, for TEPI, Julie, I know, had to leave to go to another meeting.
Do you want me to read?
Shelley has her report and can read that for her.
Julie left a note before she left. The last TEPI, we discussed each section of the Cactus Data Completeness Report for a standard percentage. Each line of the report has a 90% threshold to determine a yes or no for standard met, while each section has a variable section percentage. The committee recognized areas for improved ePCR education for EMS providers. For stroke, we discussed that if a patient waits over 24 hours to call for EMS, they would not meet the stroke alert/activation criteria, and the goal is to document whether onset or last known well time instead of duration of symptoms so that ED staff can assess TPA administration. As a standing item, we discussed the sequence for discretionary reports for 2020. Members discussed adjusting the list to make final motion restriction the third priority. We also discussed that TEPI bylaws and roster rules are due for review. Chief Mullins noted that committees were going through their bylaws as well. That's for Julie Augustine.
Thank you very much. Next, Josh for Education Committee.
Education Committee from Dr. Rice. We approved what should go into your PCR training. We discussed the STR guidance document and also reviewed the schedule for educational modules that need to be reviewed and got some volunteers to start working on the next items up.
Thank you, Josh. You're up next for PMD. I think we've probably covered that, but we'll let you see if you have anything else.
I have nothing else to add that we have not already covered.
Next, Julia for PACES.
Okay, at our last meeting, we discussed the Safe Sleep Project, education project, which has been a little bit put on hold due to coronavirus, but we will be picking that up shortly. Our national EMSC data collection of the EMS agencies closed in March, so we'll be able to have that report here soon. Also, update on the National Pediatric Readiness Assessment for EMS for Children. That has been postponed, so we'll be starting that at a later date as well.
Thank you very much. Any agenda items to be considered for the next meeting? You can let us know now, or you can shoot either myself or Shelley an email. Call to the public. All right, summary of current events. They are all currently canceled due to COVID. As things get back on the calendar, we will certainly add these back to our agenda. Our next meeting is going to be September 17th, 2020 at noon. We will again always have the online option, but we will be close to the date, figure out if we will have more of an in-person meeting as well. Big thank you to everyone for participating in this virtually. I know it's not quite the same as being in person, and we really appreciate your flexibility and participation today and doing a great job with your mute buttons. So thank you very much. Can I get a motion to adjourn?
Motion to adjourn from Maytem.
Second from Walter.
All right. Thank you, everyone. Have a good day.
Thank you. Bye.
Great to hear from you all. Take care.
Thank you.